Good morning. Welcome. I am Daisy Lehman. I am the board chair for City Club for the coming year. And on behalf of the board, I'd like to welcome all of you to our final forum of 2025. It's been a great year, and we're really pleased that you could join us this morning to talk about mental health in our community. On behalf of the board, I also want to let you know we're really excited about 2026. We've got some great programs in the lineup, including liability insurance, recreational insurance liability reform, the expansion of the county commission, an update on the Bend Central District, and many more topics for 2026. So we hope you'll be looking for our updates in your email and joining us for some of these important conversations. Taking a moment to look back, would like to just take a moment in this season of thankfulness to thank both our sponsors and our members. We could not be here and bring you these important conversations without their support. You may not be aware, but when you pay to attend a forum, that doesn't cover all our costs. And it's really thanks to our sponsors and partners that we're able to bring these important conversations together and bring the community together. So thank you to everyone here. Also want to bring your attention to the fact that we're having our second annual fundraising campaign at the moment through Central Oregon Gives. Want to encourage you, if you're not a member, please consider becoming a member, and please consider City Club in your year-end giving. It really makes a difference, and it makes it possible for us to continue to bring these conversations to the community. Also want to thank Julianne and Jim Dover. They are the daughter and son-in-law of Jim Lassier, who are here this morning. Jim Lassier is one of our founders here at City Club, and this is the Members' Choice Forum, and it's in his honor we've named it the Lassier Members' Choice Forum. So I want to thank them for being here and thank Jim for his vision all those years ago in bringing City Club together. At this point, I'm happy to turn over the mic. We've been very lucky this month to collaborate with the Oregon Health Forum, and I'm delighted to introduce Kim Crosby, their executive director. Thank you.
Hi, good morning, everyone. My name is Kim Crosby, and I am the Director of Operations for Oregon Health Forum. We are a co-presenter of today's Mental Health Services State of the Union event. I want to thank the City Club of Central Oregon for the invitation to partner and for their efforts in creating this morning's panel conversation. It's been a pleasure working with all of you, and we are thrilled for this opportunity as this is our very first forum event in Bend. Oregon Health Forum is a nonprofit organization committed to advancing health policy solutions through meaningful community dialogue. We are an affiliate of the Lund Report, Oregon's only independent news source dedicated solely to healthcare coverage. Oregon Health Forum's virtual and in-person conversations delve into topics such as healthcare inequities, industry consolidation, primary care shortages, workforce supports, behavioral health challenges, Medicaid reforms, and more. You can access all of Oregon Health Forum's previous events for free on our website at oregonhealthforum.org. You can also sign up for our newsletters for information about upcoming events. If you're interested in learning more about our organization, please visit our table that's set up in the lobby after the event, or connect with myself or anybody else wearing Oregon Health Forum badges. Thank you again for this opportunity, and I'll turn the microphone back over.
Thank you. Thank you, Kim. It's been a pleasure partnering with you and the Oregon Health Forum. Good morning, everyone. I'm Emily Boynton, and apparently I talk too loudly. And as the program co-chair and this forum's volunteer lead, I'm thrilled to welcome you to today's City Club Forum, a mental health services State of the Union. Over the past several weeks, I've had the privilege of speaking with behavioral health leaders across Central Oregon, and one thing is clear. We have passionate, committed experts working every day in a system that is complex, strained, and absolutely essential to our community's well-being. This morning, our panelists are not here to talk about the broad national conversation on mental health or to debate ideology or to point fingers at any single agency or provider. What our panelists are here to talk about is what access to mental health actually looks like in Central Oregon today, beyond the headlines. They'll examine the realities behind our high prevalence of mental health and substance use needs, at the workforce and funding gaps that shape local care, and how our fast-growing population affects outcomes. Our panelists will also lift up the silver linings. new resources, recent collaborations, and pieces of the system that are working, and hear directly from these three leaders who represent different parts of the behavioral health landscape. Our goal is simple: to give you a clearer picture of how the system functions, where it breaks down, and what each of us can do to support a healthier, more responsive Central Oregon. Our first speaker is Holly Harris, Deschutes County Health Services Director. And before serving as director, Harris served as the county's behavioral health director. And she joined Deschutes County in 2013 as behavioral health specialist and played a pivotal role in establishing the county's stabilization center and securing funding for a child psychiatric unit in the region. With that, please join me in welcoming our moderator and panelist, Deschutes County Health Services Director, Holly Harris.
Hi, everyone. Thanks for having me here today. Great to be with all of you. My name is Holly Harris, as she mentioned, and I'm the newly appointed Health Services Director. So been in the role a whopping 1 month. But again, I've been with the county for about 13 years, and again, prior to that was the Behavioral Health Director. So this topic is clearly really important to me, and I've invested a lot of time of my career in this topic and care deeply about it. So the health department, just for context, is responsible for both the public health and the behavioral health parts of the publicly funded system in our county. We're going to be spending the time talking about behavioral health today. And so just a little bit about the community mental health program. It is the publicly funded system in our county. We are a county-run system here in Deschutes County. We are not contracted out for a nonprofit. The community mental health program is a statutorily designated thing. There's outlined in statute our requirements and mandates that we have to do. And we operate at the direction of the local mental health authority, which is your board of county commissioners. The community mental health program is responsible for serving the most complex, high-needs individuals in our community. There are often individuals who cannot be served anywhere else, so we are really considered the safety net for the community. As we'll discuss more today, the system, I think Emily referenced this, the system is large and complex. It's made up of many, many system partners, a couple of which are here today, but there are many more partners that are critical to the system that are not represented here today. So we're going to be really scratching the surface of the topic today. And so we hope the information provided and the discussion that we have will spark many more conversations to come, whether it be in forums like this or elsewhere. Next slide. We're going to start off with just kind of talking about the State of Mental Health in America report, which ranks Oregon 42nd out of 50 in the nation in terms of access to mental health care. That doesn't sound very good. But it's one, I want to be clear that it's one piece of the conversation. It is not the entire conversation. Because really what this report does is it really measures the rate of prevalence of substance use and mental health in our community, but it does not measure how well the system is performing. The other challenge with a report like this is that access can mean so many different things. So we're going to spend a little time on our panel discussion, and I'll talk a little bit about it in the next slide, around the various ways in which access can be talked about and discussed. Lastly, just around this report, it ranks states across the nation against each other. So, comparing very large, densely populated states with less populated states can create some challenges. So it's not always apples to apples. So again, it's just one piece of the conversation. It is important to talk about prevalence, though. So we will spend some time on that as well today. And then also, just for kind of a positive note, the 2024 Mental Health America report had us ranked 49th. So we are going in the right direction. Okay, next slide. Okay, the report is made up of lots of different data points, so about 17 different measures that span the range of adults, youth, students, and workforce availability. And so we're not going to spend the bulk of the time today talking about this report, but we did sort of want to anchor it because this report is referenced a lot. You'll see it in our regional health improvement plan. You see it referenced in a number of other areas. So I think it's important to talk about it, but also talk about the rest of the system and maybe why some of these factors are relevant in Oregon. Next slide. Okay, so instead of focusing on all 17 different points, we're going to focus on a handful today. We are going to talk about prevalence because our need here is high. About 1 in 3 people and 1 in 3 adults has a mental health condition in the state of Oregon, so that's pretty significant. Um, there's not one cause for that. It's very multi-causal for why our prevalence is high. It can be related to things like the rurality of our state. I think we often know that in rural parts of the state, there's often less resources. So when there's less resources, people aren't getting their needs met. Housing and affordability certainly plays a role in people having their basic needs met. Other factors like just awareness and reporting of mental health conditions can also increase prevalence. So again, multi-causal, we're not going to get into all of them, but there are some key system and resource challenges that contribute to this, as well as we'd be remiss if we didn't talk about funding in this conversation, because that obviously plays a key role. So I mentioned access a minute ago and how there could be a variety of ways to think about access. So I want to talk about it from the community mental health perspective, but we are going to spend some time on the panel talking about how access can be thought of differently and what's going well and what's not going well within the different sectors of the behavioral health system. So the community mental health program, as I mentioned, serves some of the most complex individuals in the community. So these are individuals often with diagnoses like schizophrenia, bipolar disorder, who often have a co-occurring substance use disorder, who may also have a chronic physical health condition, who may also be experiencing houselessness and involved in the criminal justice system. So that's a lot going on for one individual, and that's the people that we serve at the community mental health program. If that type of individual comes up for law enforcement, or comes up for the emergency department, or comes up in a crisis setting, maybe it's a bell. There we go. We're going to remove the bell and see if that helps. Okay. Greg. Sorry for whoever's bell that was. So that individual that I just described, if that individual comes up for law enforcement, the emergency department, in a crisis system, and they need access to mental health care, we're likely going to get them in that same day or the next day. That is not an access issue that we have. We're going to get them in quickly because they're really high needs, and we need to get them to support ASAP. If that same individual needs a higher level of care, say for instance, the Oregon State Hospital, which is our highest level of care in the state, or an inpatient psychiatric treatment center, we're going to really struggle. We're going to struggle to get that person that level of care because there's just not enough resources in our community for that. On the flip side of that continuum, if somebody has private insurance and Medicare, for instance, and they have mild anxiety or mild depression, and they want to be proactive and get treatment and go see a private therapist in the community, they're likely going to also face access challenges because we do not have enough providers in our community to serve that population either. So again, access can mean a whole range of things, which is what we're going to try to dive into a little bit today. We're also going to talk about some good things today, too, though. It's not going to be all challenges. We're doing a lot of amazing things here in Central Oregon. In fact, in my personal opinion, in Central Oregon, we are leading the state in a lot of ways with the types of innovation that we're doing here and collaborations. So we're going to highlight that so that you all know what that is and can share that with anyone that you know that might be struggling to access resources. Next slide. So I love this slide because when we talk about the system being complex, this is a really great visual. And this is just, this isn't even covering everything. So I think when you look at this, you can see that there is a variety of payers, there are a variety of funding streams, a variety of community partners, resources, providers, you name it. And they all are critical and make up the system that we call behavioral health here in Central Oregon. And there's, like I said, much more. But imagine if you're a person that needs to access resources and you walk into that maze. That would be overwhelming. So we're going to spend some time talking about what a person who does need to access these resources, how they can navigate that, and who they can reach out to. Before we move on to our panel discussion, which I'm really excited about, I do want to talk about some definitions and some acronyms that we're going to be referencing today, because we are the land of acronyms in behavioral health. There are so many. But a couple of really key ones that you should know is OHP, that stands for the Oregon Health Plan. And so that is Oregon's Medicaid program, which is essentially Medicaid, a medical assistance program for low-income residents. CCO is another one you'll hear us talk about today, and that stands for Coordinated Care Organization. It's essentially a local health plan that manages care for people on the Oregon Health Plan. They work to create things like better access, health outcomes, as well as control costs for the Medicaid members. A local example of that is Pacific Source Community Solutions. So that is the local, oh, I'm sorry. Pacific Source is the local CCO for the Tri-County region, so Deschutes, Jefferson, and Crook. That's our local CCO. And then lastly, OHA. That's the Oregon Health Authority, and that is the state agency responsible for the publicly funded health system, both public health and behavioral health. And they are responsible for creating better access as well as health equity across the state of Oregon. They were established in 2009 and are based out of Salem. So those are OHA, OHP, and CCO are some terms that you might hear us throw around. Also CMHP, that's the Community Mental Health Program, which I am responsible for overseeing. So we're going to move into our panel now. So I'm going to welcome Molly Wells-Darling and Greg Lamont up to the chairs here, and we will dive into our discussion. A bit closer. Oh. Okay, I'm going to first ask you all to introduce yourself. Greg, you want to kick us off?
Hi, everyone. My name is Greg Lamont, and I'm the clinical director at Juniper Mountain Counseling. Juniper Mountain is an outpatient mental health agency, so we do the kind of weekly 1-hour appointment psychotherapy type of counseling that most people think of when they think of mental health counseling.
Hi, everyone. Ooh, I'm loud. I'm Molly Wells-Darling. I'm the Senior Behavioral Health Director for St. Charles Health System. So that is our inpatient services within the system. We also have specialty outpatient behavioral health care within our system, and we have behavioral health consultants embedded in our primary care locations in La Pine, Sisters, Bend, Redmond, Prineville, and Madras. And then we also have master's level and psychiatry services throughout our system in all of our hospitals. So we provide assessment within our emergency departments for people coming in a behavioral health crisis. And then we also have these services to patients on the floor who maybe have had a hard diagnosis that we will go and see, or patients on the floor that are having a behavioral health crisis up there.
Wonderful. Thank you both for being here and being part of this discussion. So you heard me talk up there a little bit about access and from the Community Mental Health Program, where we see access going well and where we do not see access going well. Can you describe that from your different parts of the system, how that is working for you?
So in our case, I should say in addition to individual therapy, we also provide couples, groups, and therapy for children and families. And I think one thing that we've seen going really well is when we've been able to partner with primary care clinics and with Deschutes County Behavioral Health and other organizations in the region to work to get the appropriate level of care for folks. So when a primary care provider, a doctor, can identify a mental health concern for a patient early and then make the appropriate referral to an organization like ours, that really, really helps with access to care because an individual person who may be just starting to have the emergence of a mental health concern or maybe has been dealing with it for a while may not know where to turn to get the appropriate help. So that's one thing that's working well. And do you want me to speak to challenges as well?
That would be great, yeah.
The flip side of that coin is that sometimes those referrals may not go to the right place at the right time. And so sometimes that same referral may go to a provider who is not the next right step for that person. And that can lead not only to access issues, but frustration for the individual who may just give up on the process entirely or take far too long to get to the care that they need. need, and we know that early intervention significantly increases the chances of a positive outcome when it comes to mental health.
Really speaks to the complexity of the system and trying to get people to the right place at the right time. Molly, from the hospital perspective.
Yeah, so I think of access as right care at the right place at the right time, right? And so I think what's going well is we do have our behavioral health consultants within primary care. This is a great place if you're struggling with any sort of mental health issue, anxiety, depression, or maybe just having a new diagnosis and struggling with how am I going to manage this. So that's great. We have our primary care doctors can refer to our behavioral health consultants through our integrated model to receive care. They can refer same day, either to have that warm handoff or at times for our behavioral health consultants to be able to see those patients. That's great. We also have our outpatient behavioral health clinic, which is wonderful. But when it comes to access, we are about, I'm looking at Jen because she's the manager, we're about 3 to 4 months out for prescriber appointments, and we're about 4 to 6 weeks out for a therapist appointment. So we need more access. I think a good part is that with our colleagues here, one thing that's changed, I would say, in the last couple of years is that we really are able to get patients in from our inpatient units into care in the community fairly quickly. Thank you. Thank you. Thank you. So we've really worked together, and really the county sees a lot of our patients, and so they've really worked to get that access for someone to be seen within 7 days. And we do also have that in our outpatient behavioral health clinic. As we've worked within our system to make things more efficient within our system, we have dates that within 7 days that we can get people from inpatient in. Some of the areas that are really a struggle. One is for youth. So we really do not have youth crisis care beyond the Crisis Stabilization Center, which is that 24 hours?
24 hours.
24
Well,
hours.
23 for respite.
23 for respite. So if youth are in a major crisis or they need care elsewhere, do they need care on an inpatient unit or do they need to go to a residential facility? They often come to the emergency room. And the reality of that is that they then wait in the emergency room for days, for weeks. We've had a patient there more than a month in an emergency department. So our state needs more resources for youth. Silver lining, we worked very hard together to facilitate bringing a youth facility here to Central Oregon. So April 2027, everybody wait for it, come to the opening. We, in collaboration with a community partner, will be opening that. St. Charles is not running that, the county's not running it, but we certainly have worked very hard to get funding for that facility. It speaks to the power of collaboration that we have. I think the other portion of the access to care that really impacts us and your loved ones and our community is some decisions that were made at the state level in relation to, one, access to the state hospital, and access to secure residential facilities or any residential facility for patients who are in acute care. So patients that come onto the units that I oversee, they're our most acutely mentally ill in our community, in our region, sometimes from across the state. The state hospital now rarely takes patients from acute care facilities. So we used to send, once a patient was committed, we would send them to the state hospital if they needed that level of care, and they usually would get in with a couple weeks. Now, if we're able to get someone into the state hospital, which I think maybe we've had 3 that we were able to get to the state hospital because they were extremely violent, it takes, sometimes a month or more. So that's one avenue for us to discharge our most acutely ill patients to. That's cut off, so they're staying in acute care now, which the average length of stay should be between 5 and 7 days. They're staying in acute care now for 4-6 months. The other avenue for discharge is for us, some people can discharge straight into the community. We get them hooked up with Deschutes County or outpatient behavioral health or Greg's Clinic, and that's great. But many others, if we can't get them to the state hospital, they need residential care. And the state, probably about 4 to 6 months ago, would you say, changed the access to residential care so that acute care hospitals are now fourth in line to get patients into any sort of residential care. So they wait and they wait and they wait. There's silver linings around that too, just in the amazing work that Deschutes County has done in trying to create resources and beds for us to be able to utilize. And I'm sure Holly will talk about that later. And then finally, I'm spending a lot of time on this, but I think it's important for people to know, because we don't have the ability to discharge to these other levels of care, our inpatient beds are full most of the time. And so what that means is then patients who are coming into our emergency department, they're waiting for us to find somewhere for them if they need that hospital level of care. So we have the youth that are waiting for days and weeks and months, and now we have our adults that are waiting for sometimes up to a week. It's a little more quickly we can get people in. We have to send them across the mountain, away from their family resources, away from their therapeutic resources or supports. They have to go there. So we have a lot of people who are struggling with behavioral health issues waiting in our EDs due to that lack of access.
Yeah, and I think the state hospital issue could be a whole forum on itself, and it may be at some point. So more to come on that. But really, just kind of at the crux of the issue, what's happened at the state hospital level is that individuals who have committed crimes because of their mental illness, who are not able to aid and assist their attorney in their defense, there's statutory requirements around how that is handled, and so those individuals in that system are primarily having access to the state hospital, which those beds are getting filled, which means that people who have not committed crimes, who are mentally ill, who maybe have gone through the civil commitment process, which is a process by which someone's found to be a danger to themselves or others, are unable to care for their basic needs, and has their rights removed to be able to say what type of treatment they want, their forced treatment. Those individuals now no longer have access to the state hospital. So it's a very, very complicated topic. You may have seen some things in the news. There's certainly been some things in the Lund report. I was looking for our partner here that is affiliated there. But there's definitely, it's a whole huge topic, but it is affecting the system at large for sure.
Yeah, I just wanted to comment on that, see what you think about this. But so I remember the day. I can't tell you what year, but I remember the years where we were really working to keep our behavioral health, people who struggle with behavioral health issues, out of the jail, out of law enforcement, and getting the right care at the right place, in the hospital or in the community mental health. And now we're in a situation where you almost find yourself thinking, well, if they had a crime, they'd be able to get into the state hospital faster. That's not okay.
No, it's going backwards.
We've gone backwards. I was reflecting on that last night. Yeah, so hopefully we'll get back.
And I was just going to quickly speak to that at the outpatient mental health level, that we are often seeing as a result of this phenomenon, clients whose acuity or the severity of their mental health concerns really are higher than our level of care, and often having this kind of a conversation with them, like you're not bad enough to qualify for a higher level of care. And that's the concern I often hear from those clients, is like, wait, so I need to, either commit a crime or attempt to harm someone or myself or something like that to be able to get the care that I need. That's precarious.
And we're grateful for places like Juniper Mountain and other places in our organization that are willing to help problem solve around this and take folks that maybe aren't traditionally the people they would normally serve in their settings, but are willing to kind of step outside the box a little bit and think differently about it. So it sounds, kind of summarizing, that, higher acuity folks, we don't really necessarily have access issues for outpatient, but certainly higher levels of care is a challenge. Let's bring this home a little closer to home, and talk a little bit about what happens to someone whose maybe kid or colleague or aging parent has a mental health crisis in Central Oregon. What does that look like for you all?
Sure. So I have an anecdote from last month related to this specific topic, where I ended up on the phone with a parent is sort of the conclusion of this story, but an adolescent child was having a mental health crisis, and this was identified by their primary care provider. And the doctor appropriately referred this person for mental health care. They referred the child to Deschutes County Behavioral Health. Deschutes County, as is their practice, did an initial screening with this child and determined that this child was more appropriate for a community level of care, so referred out of Deschutes County to us. And then we scheduled this client. So mom called on a Monday. This child had an assessment on a Wednesday, and I was on the phone with this parent on a Thursday. All within the same week, and the parent was very distressed, very concerned, saying, we've been waiting months to get in. By the way, we had an appointment on the schedule for this child for the following week. So, assessment was on a Wednesday, and I believe it was the following Wednesday that this child was going to be getting in for their first treatment appointment. And mom was telling me, hey, I'm really like, we need sooner. We need to get in sooner. We needed to get in 2 months ago, and it's just been assessment after assessment after assessment that you guys are doing. And I was really confused because I didn't know all of these backstory details. And in talking to her over time, I realized it's not us that's done, not Juniper Mountain that's done all these assessments, but all these different providers who have done these assessments, and they've been kind of moving from place to place to place. And so this is one of those examples where, if that referral process could be streamlined to the right service at the right time for that person, that would save a lot of time. And in this case, for this child, would have probably saved a month or more of waiting to get into services. And that's definitely a priority. It's something that we're often working on with Deschutes County, who's a major referral partner with us, of like, who's appropriate for which level of care at what time, and how do we make sure that we're directing folks to the right location to speed that access.
And that can get tricky too, right? Because somebody may present one way at the time of their assessment, and then as the days go on, their presentation changes, and maybe now they're more appropriate for a different level of care. So it gets really, really complicated really fast. Not an excuse, but it's one of those things that we're constantly working on to try to make sure that we're not creating all these barriers for folks that just want to get into treatment. And I think, the state has some responsibility in this as well, in that the amount of requirements that are put on us for assessments, to make sure we're collecting information, all the steps that are required of us to get people into different levels of care, create extra steps for people. And I don't think they want those. They just want to get in to see a therapist. It's not actually that complicated in the big scheme of things. They just want to see somebody, but there are a lot of bureaucratic, administrative burden types of activities that can create a delay in people getting the care that they need. Just while we're talking about crisis, though, and I think about this family, I think it's really important to remember we have two really major crisis resources available in our community and statewide. How many people in here are familiar with 988? That's great. Awesome. So 988 is essentially what I kind of think of as the 911 for mental health crisis. It's really intended to be a quick, easy to remember number that you can call whenever you're struggling. I think one of the challenges with 988, because it sometimes is compared to 911, is that you have to be in the most dire crisis of your life, often suicidal, kind of really at the end of your rope before you actually reach out to 988 and get some help. And that's not what it's intended for. It's intended for anyone who's having a mental health struggle. It can be as severe as something of suicidal ideation or psychosis, but it could also be having a really tough day and you don't know what to do and you need to talk to somebody and you're trying to be proactive. It could be, you're not sure how to navigate this incredibly complex mental health system and you need some help and resources. So it's really, we hope to get the word out that this is a number that you should give to people that they can call whenever they need to get help. Crisis is really broadly defined. It's, whenever your normal coping skills are just not working to respond to an event that's happening. So that's pretty broad, and you really define what a crisis is for yourself, and your loved one defines what a crisis is for themselves. There's no specific thing that says, oh, no, that's not a crisis enough. Like, if you think it's a crisis, reach out, get help, it's available. The other resource we have locally is the Deschutes County Stabilization Center. So we were the first in the state to have a 24/7 crisis walk-in facility that serves anyone of any age, regardless of ability to pay. And again, kind of similar to 988, we want people to come there for all types of crises, not just when you're, really having the worst moment of your entire life, but you just need somebody to talk to, and you can see a therapist 24 hours a day, and you receive all kinds of other supports, and also often help navigating what next steps you should take. We also have a respite unit there where people can stay technically up to 23 hours, and I know people are always like, why 23 hours? That's random. It is random. It is it's a licensing thing. So essentially, if you need longer term respite, there are options for that in the state, but most crises can actually be resolved within our average length of stay in that unit is about 10 hours. So if you just think about just need some time and space to collect your thoughts, to talk to a therapist, to get some resources and not be rushed out the door because, it's 5 o'clock and we got to close. So that's what the Stabilization Center can do for people, and I really hope that people will access it, not just, when things are so terrible that you're at risk of going to the hospital, but really much sooner than that. Come in and seek the help you need when you need it. It's there. Molly, thoughts on crisis services?
Well, one thought. If you take anything away today, 988 Crisis Stabilization Center. If you have a loved one who's in crisis or just struggling or you're struggling, these are the best resources for you to call or go to. The emergency department will always be there. We will see patients, assess them, and stabilize them. But you're not going to see a behavioral person right away, right? The other day we had 11 patients that were just behavioral health come into our emergency department at once in Bend, and we have 2 master's level people who can assess. And so, as you can imagine, people had to wait. And so if you're not in danger to yourself or others imminently at that point in time, the Crisis Stabilization Center is really a great place to go to be able to see someone who has that behavioral health expertise right away. It's home-like, and it's a wonderful place. So that's probably what I would just highlight in that.
Yeah, and we want to see people, you're just going to get a different experience than when you go. ERs are not set up for, having people stay for very long periods of time. There's lots of other traumas going on, things that they're intended to deal with. And so it just is, if you want a kind of a calmer environment in which to get your mental health needs addressed, it's a great place to start. Now, obviously, if there is a significant danger to yourself or others situation, the hospital is the right level of care for you to get that need met. But there's a lot of things in between there.
Just one more thing to add based on that. Sometimes people really, what they're wanting is for their loved one to get inpatient care. And so you don't necessarily have to go to the ED, as the first line in seeking that. You can go to the Crisis Stabilization Center. They're skilled at assessing whether someone really needs that inpatient level of care. They're skilled at finding other resources within the community that can support you while you're at home. So I just wanted to add that you really can go there and they can assess. And then if they feel like, this person really needs to be inpatient, they can actually call the hospital, find out, do we have beds, send patients over, coordinate with us. So just one more thing on that, yeah.
All right, we're going to switch gears here a little bit, and because we'd be remiss if we didn't talk about some funding challenges and what we're facing right now. Obviously, from the community mental health program perspective, we know we have existing parts of the system that are already underfunded. Some of our more critical services, like some of the stuff I've described today. There's cost studies that have been done that demonstrate that we've been underfunded in those areas. There have been significant investments from the legislature over the last couple of years, but prior to that, there wasn't much investment in behavioral health, so we're playing catch up on that, but we're really grateful for the investments we have gotten the last few years. They've been significant. A couple things that I think about for the future. I kind of call it, the trifecta of funding uncertainty that's causing me to lose a little sleep at night. The first one really being around the CCOs. So we talked about the definition of that, the coordinated care organizations that are responsible for the Medicaid population, the Oregon Health Plan. If you've been reading the Lund Report, if you've been reading other news articles, you'll see that CCOs are really struggling financially across the state. That's including the one that we work with locally. And so part of the reasons for that, they're multifaceted, obviously, but part of the reasons are that when CCOs were created back in 2012, I think, they looked very different than they look now. There have been a lot of expansion of services, increased access, more requirements, lots of things have been added to the CCO model over time, some really great things. And then we have the rates that they're being paid haven't necessarily kept pace with the costs of providing those services. I think we can probably all relate to that right now. That is not a unique phenomenon to CCOs. It's kind of a phenomenon everyone's struggling with. So there's some fiscal uncertainty there, and we're going to have to wait and see how that plays out. The other one I'm paying close attention to is the state budget forecast. If you've been paying attention to the news there, you'll see that state agencies were recently asked to propose a 5% reduction. So that will be going before the legislature soon, so we'll see what type of cuts are proposed and how those play out and how that may or may not trickle down to our local community. The third and probably biggest one is related to the federal legislation that passed, H.R. 1, also known as the Big Beautiful Bill. This legislation has some significant impacts to Medicaid, including things like work requirements, eligibility requirements, co-pays, a whole slew of other things that we could spend an entire forum on as well. And so this will have we know it will have an impact to our Medicaid population. One of the things we're really looking at is around historically people had to redetermine their eligibility every 2 years, and now with this new legislation, it will be every 6 months. So there's a lot that goes into determining eligibility, and if you can imagine, if you're struggling with a significant mental health condition, keeping up with that every 6 months could be a challenge. So people may fall off their Medicaid, but are still technically eligible. But also, even if they don't have insurance, they still have need. So this is where the community mental health program gets a little nervous, because we're still gonna serve folks because they have a need. They are a population. They're our people, but we may not be able to get the reimbursement that we have historically gotten. So those are the things that I'm paying attention to right now. I'm curious from your perspective, Greg, what this phenomenon is making you think about.
So it's important to define that Juniper Mountain has a COA, a Certificate of Approval with the state of Oregon, which means that we have voluntarily subjected ourselves to a higher level of scrutiny and accountability on the state level for how we operate. And historically, having that certificate of approval has allowed specific, privileges or benefits or improvements, whether that's in reimbursement rates or how we can bill or which services we can bill for. But the inclusion criteria for some of those benefits is sort of ever changing, and the state, the OHA, has rewritten those criteria a number of times, and then the CCO may interpret those criteria in different ways. And so I think one of the challenges that we have faced is receiving annual audits and every 3 years audits from the state that require a much higher level of administrative burden, a much higher level of oversight of our clinicians, and just a higher kind of quality assurance program, which is costly to us, hasn't really been incentivized in such a way that allows us to keep operating in that way. And so oftentimes we find we're sort of operating on a razor's edge to try to maintain that level of quality while also pay our staff at a rate that's appropriate and competitive within the workforce. And so I think there's some equity concerns I think that I have related to funding and making it really clear on a state level, and then within the CCO, how folks are going to be paid and really incentivizing quality of care, because there's a difference between a certificate of approval organization like ours and what we have to do day in and day out in terms of documentation, in terms of the care that we provide, in terms of the oversight, that I think ensures a higher quality service in a number of ways, but it's not always viable to continue to do that. And I think this is, part of the reason why we can serve some higher acuity clients and we can absorb some of the other challenges in the region is because we have that kind of higher level of scrutiny and higher level of accountability. But without a higher level of pay, then it's really hard to keep pace with the industry.
Yeah, and it certainly has an effect on the workforce issues as well. When you have options to go work at a place that does not have these high-level administrative burden tasks associated with them, and you can be paid the same or sometimes more, it makes it really tricky to recruit workforce. Any thoughts on?
I would just say we've lost lots of employees, right, to go to that private area where they don't have COAs like we both do for our clinics. The gap is wide. It's deep and wide in terms of reimbursement for behavioral health. So this is why, and the Medicaid, changes in Medicaid are really going to impact us. Like Holly, we see all patients, and if a patient needs to be inpatient, they come inpatient, insurance or not. So I think from my standpoint and with my teams, what we're focusing on is, okay, we've already had a gap. There's probably a larger gap coming. What do we do about that? How do we become more efficient throughout our system, in all areas of our system, doing the work in different ways to help take care of our patients and to be able to continue to provide the care that we care now, and hopefully to be able to continue to work on the continuum of care with our partners. So I think we've always been extremely strong in this region at coming up with what's needed in our community, really scrapping. Really scrapping to figure out how do we bring that. The youth facility is a great example that acute care and Holly and I really worked very hard on with our colleagues across the region to get funding. And we did it in a year. It took 10 years, you guys. We talked about it for 10 years and probably about 3 years in planning, but then in this last year, we were able to secure all the funding that we need for that facility. So we're really strong in that way, and we can all list a number of projects that we've collaborated together. So really, when I think about funding in behavioral health, now more than ever is when we have to collaborate. We're stronger together. We're stronger together when we go to the state and say we need this, because this region is underfunded for multiple things. Most of the money goes to, the Portland area and Salem. So I'm really just focusing on that. I can't control the other changes that are happening around. And so what do we need to do together? Holly and I just before this were talking about, hey, we need to do this and this. How are we going to do it? And what's our focus going to be this year to make that happen collaboratively with each other? All of us, yeah.
So whenever there are scarcity of resources, priorities need to be set. What thoughts do you have around what are the key priorities that we need to make sure are funded in order to keep the system afloat? Greg?
I think we've already spoken quite a bit about funding these higher level of care, whether it's inpatient care, intensive outpatient care, kind of like intermediate levels of care. We don't have enough of those higher level of care access points, particularly in Central Oregon, but really across the state. And so I think there's desperate need for increased access there, and I think that is likely a funding piece. I have heard from psychiatric prescribers, from folks looking into intensive outpatient treatment and others, that the reimbursement rates just aren't really there to incentivize having those programs in place. So I think funding in those areas is very, very important. And then I think just having much clearer standards on what is being funded and when. It seems like an ever-moving target, and I think probably some of that is that mental health as health care is something relatively new. Mental health as a healthcare service has only been covered reliably by insurance for the last 10 years, 10, a little more than that, decade. And so I think we're still really trying to figure out where mental health fits in to the healthcare system. And we need much clearer standards for how that care is defined and how it's paid for.
Molly?
Yeah, ditto. I think really our crisis services are so important. We need more inpatient beds across the state. We need more here. But also we have to look upstream, and we need to have a expansive continuum of care so that patients don't really need to come into an inpatient bed. It's better to be able to take care of our loved ones in our home if we can. So I would say crisis, absolutely. We can't see our crisis services get any, we need more crisis services, so we can't pull back on that. So crisis funding is very important. I would say from the hospital perspective as well, residential facilities, secure residential facilities, which are facilities that are locked where a patient can go and stay and get the care that they need. Really important. Youth services. Yeah. Partial hospitalization too. We really need that. Yeah.
That's what we were just talking about.
What you're talking about.
Yeah, I couldn't agree more. The continuum of care is critical. I think, crisis services, just to speak to that for a minute more, we do not, our stabilization center has had at-risk funding since the day it opened. We did not let funding be a thing that stopped us from getting that facility going. So we have an incredibly complicated braided funding model to keep that facility operational at 24/7, because we believe 24/7 is critical. We don't think people should have to wait till the next day to get their crisis needs met. They should get it met when they need it met. And so that's going to be a piece, we want to, in my opinion, I think we do need to make sure crisis service, in particular, as we go into these next couple of years with fiscal uncertainty and people potentially being no longer insured, that they have access to some type of care when their needs arise. So that's definitely one of the areas I support as well. I think, to your point, being more upstream, this is where a public health hat on, prevention. We have not spent enough in the state in terms of prevention work, and that funding is always at risk. And I think the more way upstream we can get, I think as a state, because some of the challenges at the state hospital have been such the focus, that's where primarily the higher levels of care is where the funding is going, and I do support that, but there is just not a lot left for anything more upstream. So I think focusing on that as well would be important. I believe we are at our final question. Am I doing good on time? Okay. All right, so this is where we get to talk about the fun stuff. In terms of what is, in your opinion, Molly, I'll actually start with you. What is the North Star for Central Oregon in terms of access and outcomes?
I go back to the right care, right place at the right time. In order to do that, we have to have a continuum of care that provides that at every place for every person that's right for them and their care. So I would say that's the North Star. I think we can get there, but it does take time and it does take collaboration. And we're in a period of time now where we really do have to come together as partners for our community and the community involved as well, to identify what is it that we need and how are we going to do it.
And I think we're making some headway on that front. So this is where I want to talk about some of the cool things that are happening in Central Oregon because of the grassroots collaborative effort locally to try to problem solve some of these issues. So we've talked a lot about the lack of residential care. Well, good news on that front is that in the next 2 years, we should be adding around 40 beds to our community in Deschutes County. So that's significant because if you think about the last 20 years, we've nowhere near added anything close to that. I don't think we've added much at all for this particular population. There have been some inpatient spaces developed, but when we're talking about the Oregon Health Plan population, Medicaid population, there's not been a lot added. So, and our community's grown, you all see it. So this is going to be a pretty big, and it's not just going to be one type of care. So we're adding We have different types of residential care that are available to people. Some residential care could involve like group homes, so where individuals with a mental health condition live together in a residential area with some on-site support and case management. We're adding 10 of those beds in Deschutes County. We are adding the 15 beds for youth, finally, the first of its kind in Central Oregon that will serve the Tri-County region. That is huge. It's so needed, and really grateful to the support from our elected officials to help get that done. And then we're adding 15 beds of the secure type of facility that we described. So again, this continuum that not everybody needs secure, not everybody needs outpatient, not everybody needs, you know, all of these different things. So having the availability for what they need in our community is huge. So more to come on all of that, but those are all happening. And next 2 years, we should really feel the difference once 40 beds come to our community. Greg, anything you want to add on this?
I mean, I agree, the right service at the right place at the right time is essential and is a guiding light. One of the things that I really hope we can continue to invest in and improve is educating the public effectively so that that can happen. Because even if those right places exist, if folks aren't getting to that right place at the right time, then it's not going to make a significant difference. And so I think educating the public, educating our healthcare system, integrating information so that our healthcare medical providers have the right information and are connected to the right mental health providers, that's huge. And then above and beyond that, I think a secondary guiding light for me is quality of care. You know, we're mostly talking today about access to care, and if you can't get access, then it doesn't matter. And so that's, of course, the first line. But it's also really important that that care be of high quality. And I think one of the things that's really important to ensure that is moving beyond just providing evidence-based treatment. So for those of you who aren't familiar with that, that's the idea that the treatments being provided have an empirical basis that they are effective. There's been good, solid research supporting that those treatments are effective. Now, the reality is any given evidence-based treatment has a certain percentage of folks who will still not benefit from that treatment. And so if we are just sort of sitting back and saying, hey, we're providing the evidence-based care without evaluating whether that care is working, is effective, then I don't think we're being faithful to those clients. And so I'd like to see more of an emergence of what I will sometimes call treatment-based evidence. So really kind of looking at, measuring, paying attention to client outcomes and making changes sooner to their care when treatment is not effective, looking into alternatives. And right now that's not easy. If I have a client with intractable or what's sometimes called treatment-resistant depression, getting them in for ECT or for ketamine treatments or some other kind of like alternative or emerging forms of care can be really challenging. It's not straightforward. And so I think we need better accountability and better oversight of our mental health clinicians and mental health practices. Are these really working? Are clients in therapy for 10 years and seeing no change in their life, but they like going, they really like their therapist, and so they just want to keep going? Or are they actually seeing improvement in their mental health? And I think we can do better at paying attention to that, measuring that, and improving our outcomes, which I think will also have a byproduct of improving access because we won't have as much of a gridlock in terms of the care that's available.
Absolutely.
One more thing to add. This will make you happy if you haven't heard it. But St. Charles is starting ECT. So, so right now for
Say
ECT,
what ECT is for those who don't know.
electroconvulsive therapy, which means it induces a seizure. And then I don't know all the medical stuff, you guys, so I'm not going to be able to say it, but it induces a very small, short seizure. It's a 15-minute procedure beginning to end. It happens within one of our same-day units where you go get your colonoscopy or things like that. So, and then they have recovery. But right now, for our region, people have to go to Peace Health in Eugene. And it's very hard to get into. OHSU does a little bit as well, or they go outside of the state. So this is a treatment it's an outpatient treatment. It's usually 4 to 6 weeks, 2 to 3 times a week. Great outcomes for treatment-resistant depression, for some schizophrenia. It's also been used in Parkinson's. So we're really excited about it. I think we have our first case in a week or two. So if you're interested, on the St. Charles website, you can go there. We have an ECT page. You have to be a provider, so you need to talk with your loved one or your prescriber or your primary care doctor. They can make a referral on that page. They fill out the information, and then you receive an assessment from our consult liaison, Dr. Streck. And then if he feels that you're appropriate to be treated with ECT, then we can get that set up.
That's very exciting. Yeah,
very exciting,
that's really,
yeah.
really great. And just kind of back to your point, Greg, about people not being aware of the resources. Well, we hope forums like this help people become aware of the resources. So we really depend on all of you to please share that, we have a stabilization center. I'm always amazed because I spent so much of my life working on getting the stabilization center open. And so I just assume everybody's heard of it. You all know what it is, but that's not true. I'm finding that more and more when I go speak to people, they're like, oh, we have that? So, we obviously need to do more in getting the word out so that people know how to access these resources. And so we'll continue to work on that. But all right, so finally, if the audience could walk away with one thing today, what would that be?
I guess I go back to the 988 and the Crisis Stabilization Center. I think those are really important. And if you don't know what your loved one needs or what you need, you can call them and they can help you figure that out, right? Our system is so complex and hard to navigate. I've had that myself where colleagues have called me or my own family, and I'm like, all of a sudden, whoa, what do I do? Who do I call now? So those are two avenues that really can help you just figure that out. So I would say that, to walk away with that and to spread that word.
I would say, like for each of you personally, if you have been, are, or ever will be a client of mental health, that if the initial getting into care is slow or challenging, keep with it, because once you get in, that tends to really be the tipping point where things start to really improve. So just maybe a little bit of encouragement that the care is there and available. We're just maybe not as efficient as we'd like to be in getting folks connected. And then in terms of like kind of the public movement, I think it's education. Education for our communities and for our providers, what the levels of care are, how we can access them, and helping those providers to stay connected with one another and be in more easy communication with one another. I think that's the game changer.
Yeah, I think I would totally agree with both of those. You stole what I was going to say, but I also think that a really important takeaway today is that, yes, while we're facing some challenges going into the next couple of years, I think Central Oregon is poised well to manage those. One of the things we do incredibly well here is collaborate with our community partners. We do not operate in silos here. We depend on each other. We rely on each other. We support one another. And we're going to figure out collectively how to get through the next couple of years and make sure that the people of Central Oregon get the care that they need. So that's a priority for all of us here. So that gives us hope, right? We gotta have hope as we go through this. Anything our audience can do to help with any of this from your perspective?
Well, a couple different things. Spread the word on 988 and crisis stabilization. I've already said that. In relation to helping people who are suicidal, if you own a business or you know someone that owns a business or you work in an organization, QPR is a really great thing. Question, persuade, refer. And so people can come in and I think it's like, is it 2 hours?
Yeah,
from what I recall. It's a 2-hour training. They can do this for your staff. This will help your staff not only to be able to take that back if they have loved ones who may become suicidal, but also in the work environment. You know, it helps you to look for those cues of a colleague who may be struggling. So I would say, you know, that's, yeah.
Yeah, maybe just to sort of internalize like outpatient, crisis, hospital as these three layers of mental health care, and helping to kind of spread the word and try to funnel people into those appropriate three categories. You know, crisis is always an option that will get folks plugged into the various places they might need to go, but then a huge difference between hospital and outpatient level of care. And if even just like those three things were on each person's mind and we did a better job educating that, I think that would be a big difference. So outpatient care, crisis care, hospital care.
Yeah, and what I would add is that we have a really engaged group of elected officials that care a lot about this topic. I mean, this is a topic that gets talked about in nearly every campaign, every election cycle. Healthcare is always on the top of the list. So I would say if you heard something today that you're like, we need to do more about that. We need to fix that. We need more resources for that. Bend the ear of your legislators. They care. I mean, we would not have the child psychiatric facility coming if it were not for our elected officials actually coming here, listening and understanding the problem, and then really advocating in the legislature to secure funding for that project. So it works. They listen. They are engaged. So I encourage you to reach out to them if you've got ideas. All right, I think we are finished with our panel discussion and now ready for some Q&A. So,
All right, so just a reminder, your questions, keep them brief, and your questions should end in a question mark. So don't forget that. But if anybody has a question, feel free to raise your hand and I'll bring the mic to you.
Great, thank you, Holly. Thank you for being here, City Club, for bringing this to our attention and creating visibility and the awareness. The Stabilization Center, I recall that many years ago when you were fighting for funding, and how it's scaled now to the 24/7, or 23/7 if you want to call it that way. But one thing I wanted to call out on that, as I believe is a positive, and I think is still working today, is how it has helped our Deschutes County law enforcement, our sheriff, by not having to take them directly to the hospital to put impact on resources there, but to bring them to the stabilization center so that they can be assessed and let the sheriff get back in the field and do what they can do. So it'd be kind of neat to elaborate a little bit on that. And then Greg, on the awareness and education, we talked about the QPR, which I had no understanding about what that was, but I'm curious from a business perspective, how can we be more engaged on that QPR piece? What is the process and how do you approach that and where do you get the resources?
great. Yeah, thank you for bringing up the law enforcement piece of things, because absolutely one of the reasons the Stabilization Center was developed was because our law enforcement were responding to the community repeatedly, over and over, for individuals who are experiencing a mental health crisis out in the community, were getting called out there, which is not really a law enforcement thing, but that's what they respond when they're called. And so they would go out there and then they would have no other options. They couldn't leave the person in the community, so they would take them to the hospital. And what we found is that most of those people really didn't need a hospital level of care. About 75% of it, we did some data mining at the time, about 75% really could be served in the community, but just needed a little more time. And so at the time, law enforcement was spending, quite a bit of resources and effort going to the hospital, waiting for them to be assessed, only for them to be released back to the community. And so that's really what started the conversation around the Stabilization Center. So now they can bring people voluntarily. Our facility is entirely voluntary, and that model works well. But they can bring people to the facility in lieu of taking them to the hospital, in lieu of taking them to jail, which was the other option. They could charge them with some low-level crime and take them to jail. They had that option too. Instead, they can bring them to us, and we get them in and out in about 4 minutes, so that law enforcement can get back out to the community doing what they do best, which is protecting our community and public safety. So that was a huge resource. We've, in addition to that, added the ability for our mobile crisis team, who's embedded at the stabilization center to respond to the community without law enforcement now. So we're one of the few counties in the state that have the ability to respond 24/7. We are connected to the 911 dispatch system, so calls don't even go to law enforcement anymore. They come directly through the 911 dispatch system to a crisis worker who can then respond without law enforcement. And about 84% of calls that used to involve law enforcement now come to the crisis team and can be resolved without having to use that really critical resource. So we're really proud of that. It's working. Law enforcement I think, is a pretty big fan of our facility that wants to see it remain 24/7, and we continue to have lots of support from them. So thanks for bringing that up.
Did you want me to expand on QPR as well as, okay. So it's a training that really goes through identifying risks or identifying things that you might see in someone who's struggling who may be having thoughts of suicide. And then it maps you through from there, identifying that. How do you question? How do you talk with your colleague who you worried may be thinking about hurting themselves or killing themselves? So what are the questions? How do you engage in that dialogue? And then persuading them to get care. How do you navigate that conversation? And then referring them, so getting them to the right place to help them. That's essentially about a 2-hour training. In terms of how you can receive it, I believe the county's still doing this through their suicide prevention, Central Oregon Suicide Prevention Alliance, and through, you have a suicide prevention team. I'll let you talk about this, but they offer QPR and will engage and go into businesses and do that.
Yes, so you can reach out to Deschutes County. We can help get that set up. We actually have one of our trainers right here in the front row. The Central Oregon Suicide Prevention Alliance is a group of community members that focus on suicide prevention. But we also have in public health department, have a suicide prevention team that specifically provides these types of trainings and other activities to prevent suicide.
And I'll just say, similar to the more of us in this room who are out there walking around who have training in CPR, the better off our community is. Similar with QPR. Typically with suicidal intensity, that's an acute type of thing. Someone might experience suicidal ideation over a long period of time, but the window of time that someone is really seriously contemplating intent for suicide tends to be brief. And if we can help someone to get through the 24 or 48-hour period of intensity, we can drastically reduce their risk for suicide. And frankly, if someone is talking to you about their suicidal thoughts, they're not doing the act of suicide. And so just getting someone talking and in connection, in relationship with someone is like a big portion of the helpful part. And so if anyone's even remotely considering getting some training in QPR, I'd strongly encourage you to do it. It could save a life.
Absolutely. One of the things I love about it, it really reduces the myths associated with talking about suicide with people. That by talking with somebody about it, you're not actually increasing their likelihood that they're gonna do that. So it gives people comfort level and being able to have the conversation.
Hi, I'm Tracy McDonald. I've returned to Central Oregon. Was with the county for a number of years, but so I'm in private practice now. Something that I've always seen is there's so many individual providers in the community. So less acute, less hospital stabilization, but like there's one-off therapist here, one-off therapist here. I'm now in a practice with 3 providers. How do we refer? Does the stabilization center refer to who, or that St. Charles has a 4-month wait list at their behavioral health? I offer some patients Psychology Today, but if some therapists aren't on Psychology Today, what do they do? So I don't know if that's, it's kind of at the step down level, but how do we bring the community and access to patients that maybe do have insurance or a little bit more resources?
Yeah, I mean, I think this is where crisis staff, hospital staff, others are really skilled, and our access team at the county really skilled in understanding how to navigate people's individual insurance. So if they do have private insurance, really helping them understand who's eligible, who's in their network, and how to get them connected. The problem we run into is there's often wait lists. Significant wait lists with getting people to those providers, I think, is one of the challenges, and all the challenges that come with different types of insurance. Actually, Oregon Health Plan, one of the easier. I mean, like if you have Oregon Health Plan, there's a lot of options. If you have private insurance, there's less and less options. So that's a challenge. I think I don't know if you have thoughts from your perspective.
Yeah, I think this dynamic is near and dear to my heart. That I mean, in my mind, there's not necessarily a shortage of providers, but a shortage of the certain type of providers. I mean, you could throw a stone anywhere in Central Oregon and probably hit a private practitioner's office. But those are, that's a certain subgroup of clients needing care, and those folks can only care for so many clients. And I think that's where funding to incentivize, whether it's, certificate of approval agencies like ours. Just side note, we have no wait list. I can get a client in within a couple of weeks. Or even higher levels of care from there. I think there's right now, the system is set up in such a way to incentivize clinicians to go into private practice, because that's where they can make the most money for the least work, essentially. And I think that is a barrier currently to attracting clinicians to employment in these higher levels of care. And if we can't staff them, then we can't really run them.
Yeah, the county has a great team who does know the insurance and how that works. But I would say also, if you're in the community and you're not connected to care, and you're wondering who should I go to, just calling your insurance company and finding out who's on my panel, who's seeing people, this is what's going on for me or my loved one, and then they can give you the names and numbers to call.
Hi, my name is Adam. I am leading wilderness-based programs for men and rites of passage work for boys. And I'm curious, you spoke a little bit about the alternative modalities that you may be sending patients to. Are there currently avenues for people like myself, who I'm not traditionally credentialed, to receive access to these patients? Do they have access to alternative modalities like wilderness-based programs? Right, you talked about our youth having lack of access. I know there's plenty of people like myself who are not involved in the traditional mental health scene. I don't know how else you refer to it. I'm a musician, I call it a scene. And if there are not those avenues currently, what are the obstacles to having those kind of relationships and collaborations? I've reached out to a lot of different clinics around town to say, I'm here, and I haven't gotten a lot of response. I don't know if that's just a natural bureaucracy thing. Can you speak a little bit to how we can create more openness for those types of dialogues and collaborations?
Yeah, I mean, my guess is payment. That the population we're serving, OHP is likely not covering. I mean, you could tell me. I mean, if your organization accepts Medicaid, I mean, that's primarily the population we're serving, or folks with super high acuity needs. Wilderness therapy can often not be a place where they start. We need to get their kind of mental health, stabilized, particularly for our youth, get it stabilized before some option like that is available. If the family has resources to be able to pay for that, I think that's probably our biggest barrier. And so, advocacy at the state level for alternative therapies to be available to all would be amazing. But right now, I think that probably is our biggest limitation.
We have referred to programs like that in the past. I think one of the limitations is how quickly can we get them in, because they are sitting in the ER. But we have done that in the past. I don't recall that we've done it, anytime recently. But happy to connect afterwards, and maybe we can have you come and talk with the staff about what you provide and see what we can do. But Holly's right. The OHP is typically who we're seeing, but we do see youth with private insurance and private means as well that could possibly pay. So connect afterwards.
Hi, I just want to share a resource. So I'm Jennifer Houth. I'm the Director of Student Wellbeing for the Bend Pine School District. And we have been, we partner so closely with the hospital in Deschutes County. I'm so thankful for our relationships and our collaboration. But I do just want to share a resource that we've been partnering with for the last 4 years. As we have 18,000 students and 3,000 employees, but as we navigate the behavioral health needs of our students and families. And so we've partnered with Care Solace. And so any student that needs access to mental health, psychiatry, substance use, families, staff members, brothers, like it really covers almost 80,000 people here in Ben Lapine Schools. So if you go to our website, if you are a staff member or a relative of a staff member or a student or family, it's like a VIP concierge for mental health. So those, back to your question over here around the Psychology Today, you can go in and say that you have MODA, that you're looking for outpatient, and if they're looking for a certain affinity. So there's different kind of ways that you can drill down on support, but they're a close partner with us. We couldn't do it without them, and so I just wanted to make sure that our community knows that Care Solace is available.
Sorry, we're a little contingent over here. I'm Lucy Parkinson, Melissa DeMeyer. We're from the OSU Cascades Counseling Program. And one thing we just wanted to lift out too, just to have a forum like this, to have a community conversation with people from all different ecological systems within our community is so important. And a lot of people also don't know that OSU Cascades has a master's program in both school and clinical mental health counseling. And so I'll frame my question as mental health educators, what are ways that you see the university being able, and I know Shannon Lipscomb's here as well. How can we be good partners in this conversation, and what might be some follow-ups to this forum that would be important for people who are interested in continuing the conversation?
I love that question. Yeah. We were kind of just talking about this earlier. I think, the population has changed over time. I think when curriculums were developed around mental health counseling, there's still absolutely a place and time for kind of traditional outpatient therapy for people with mild, moderate conditions to get treatment. That's a model that's tried and true. Where I think we're struggling to have clinicians come out of the higher education system is be prepared for the type of population that I've been talking about today. So the multi-system involved, multi-symptomatic individual who is just really, really acute. We're finding clinicians are not prepared for that. So obviously the community mental health program can be a great training ground for that. We have a very robust internship program. I'll put a plug in for that. And that can be a great way to get them up to speed. But I've actually been talking with the state about this around, is there opportunity for us to create a track within higher ed that really is specific to the publicly funded system, to the higher acuity needs of this population, so that people, and even in the crisis system, because most people who come out of higher ed don't have a true understanding of what it means to be a clinician in the crisis system. And I think the ones that ultimately figure it out and find their path there love it. So if we could get them exposed to it earlier on, we may not have the crisis workforce issue that we have of not being able to find people to work in that system. So if you're interested in collaborating on that, I'd be all ears and be happy to talk with you further about it, because it is a passion of mine to get people prepared for this type of work.
Yeah, I think I would second that. I would say, OSU Cascades specifically is uniquely poised as a local program to educate students about our local resources and systems of care. But for higher education generally, I think a stronger focus on crisis and crisis intervention could be quite helpful. Specifically, a lot of times clinicians that I'm working with who are newer to the field, maybe I'm supervising them, will have a client with some suicidal intensity in the room with them, and they're not clear, do I call 911? Do I call CCRT? Do I call their emergency contact? Do I call anyone? And at what level of, distress or intent does that choice tree change. I come across, not OSU Cascade students in particular, but I think just graduate students across the board and newer clinicians who don't have a familiarity with how to make those decisions when a client is in crisis. Yeah.
I would just emphasize the same thing, and we would love to work with you as well. So it would be a great team to get together with you to talk about that. But having people prepared to deal with people who are suicidal, people who are psychotic, it's people who are psychotic. It's a little bit different way of working with them. It's super fun work, but it can be really scary for any new graduate. So having a pathway to train on that would be fabulous.
Okay, you get the last one.
Yeah, one thing that you didn't mention are the substance abuse resources in our community, which plays into this. It's a big part of it, and I just wondered where we are with that. And one other thing, where is the youth treatment going to be located? Is that here in Bend?
It's going to be in Redmond.
In where?
Redmond.
In Redmond, okay. And also, and I guess you can't talk about housing and transportation and the other things that affects this population, but that's a big.
I could, but we'll be here a while.
That's right. Good. Thank you.
I can touch on substance. I mean, it's an area I think that we've got outpatient resources for substance abuse treatment that are we've got a wide variety of those at the community mental health program. We do co-occurring treatment for people with significant mental health issues and a co-occurring substance use. Where we're lacking is inpatient residential care for substance use disorder treatment. So that's, we have Best Care, which is a huge resource for that. They've got a detox facility in Redmond. We've got inpatient facility in Redmond and Klamath Falls as well. But it's not enough. So I don't know if you have.
It's not enough for sure, but we also have a partnership, the hospital has a partnership with Best Care. We have, it's called CET, but I can't remember what the acronym's for, but it's basically peer resources that are coming into the hospital. So if someone comes into the hospital and they've had an overdose or they have a medical issue related to their substance use, these individuals will come in from Best Care and see them and partner with them, and then they will follow them in the community and get them connected. So it's a great resource. We're thankful for it at St. Charles.
I'll just say that Juniper Mountain doesn't specifically do substance use disorder treatment, but something we see on a regular basis is that substance use disorder treatment without mental health treatment often has a higher occurrence of relapse. And so just the importance of recognizing that co-occurring piece, that mental health and substance use often go together and may need multiple different types of treatment. There's the support in getting sober and staying sober, and then there's also the support around why that person might have turned to drugs or alcohol in the first place as a coping method. And then to the question that you didn't ask, I think Holly and I were speaking about this before the forum, is just that mental health care is not the answer to all problems, is not the answer to all social problems. And I think in some ways it's been sort of propped up there as like, oh, if you have a social problem, go get counseling and it'll be all better. And mental health care won't resolve isolation. Mental health care won't resolve a lack of access to basic resources. And so I think we also need funding in those areas as well, social supports, so that people can get transportation to their appointments, so that people have access points to community and connections. Oftentimes that's a less than ideal, if not misuse of mental health care is I don't have any friends or loved ones, but my clinician is a reliable person I can talk to. That's okay for a while, but if we're not helping that person to actually get connected to genuine community, it's just a Band-Aid.
All right, I think we've wrapped up this conversation, although there's obviously so much more to go. I'm Amber Thatcher. I'm the Executive Director of City Club. Good morning, everyone. I just want to thank again our panelists for their time and their passion that they brought to this very important conversation. So if you can join me in giving them a round of applause. Thank you as well to the planning team. I say this every forum, but it does not change. A lot goes into bringing these forums to light, and this complex and important topic especially had a lot of iterations and conversations behind it. So thank you to the forum planning team as well as Oregon Health Forum for collaborating with us on bringing this to the community. Thank you again to both sponsors for both City Club and OHF. As Daisy said at the beginning, we couldn't do it without support from our sponsors, from our members, from our donors, and a reminder that we are in year-end giving and we are participating in Central Oregon Gives. So please keep City Club in mind with your year-end giving plans and beyond that. And be on the lookout for 2026. We have a lot of great stuff, I think, through the first half of the year already kind of lined up. So lots more to come, but we are looking forward to seeing everybody in 2026 and wish everybody a happy holiday season. And thanks for attending this morning. Have a great day.
Thank you.